Transplant recipients have 100 times increased risk of neoplasms due to prolonged immunosuppression. They have a 6% incidence overall, and they're usually skin cancers and lymphomas. And they can also be urothelial malignancies or renal cell carcinomas. These, on ultrasound examination, these malignancies can appear similar to hematomas, abscesses, lymphomas, or seromas, or other space-occupying, well-demarcated lesions within the either intraparenchymal or within the periphery of the kidney, and should be differentiated from those with with further imaging testing. Renal cell carcinoma can occur in a graft recipient due to introduction of a carcinomatous graft, or there can be renal cell carcinoma development in the patient's native kidney secondary to immunosuppression. It's less aggressive in the graft than in the native kidneys. 90% of adenocarcinomas are in the native kidney. It may be because half of hemodialysis patients for chronic renal failure eventually develop acquired renal cystic disease, with 9% of those getting tumors. Treatment involves a partial or total transplant nephrectomy. Urothelial malignancies are also increased in graft recipients. Lymphomas in the transplant population tend to have more aggressive, atypical features not commonly seen in the lymphomas of the general population. And they tend to be associated with Epstein-Barr virus, and they're seen in 1% of allograft recipients. Post-transplant lymphoproliferative disorder is seen in 8% of transplants and is diagnosed approximately 80 months after transplant. And you can look for lymphadenopathy on CT with contrast, and ultrasound can be used to guide for core biopsy. Glomerulonephritis recurrence is more common with diabetes, amyloidosis, and cystinosis, and it tends to be the most common cause of recurrent native renal disease. And it's usually incidental but subclinical. Patients with active vasculitis and oxalosis pre-transplant have a higher incidence of renal damage in the early stages, and ultrasound is not useful except to exclude treatable causes of reduced renal function. Alright, now we're going to do the quiz questions. The first one is, what is the research design of this article? A. Randomized control trial, B. Cohort, C. Case series, D. Review, or E. Cross-sectional. The answer is D. Review. Question 2. Which of the following statements is false regarding indices that quantify flow in the renal allograft? Doppler RI equals peak systolic velocity minus end diastolic velocity over peak systolic velocity. This is true. Pulsatility index and resistive index are the most commonly used ratios. That's also true. Additional possible ratios include systolic-diastolic ratio and diastolic-systolic ratio. This is also true. An elevated RI greater than 0.8 is used by some as a nonspecific parameter for renal transplant dysfunction. This is true. This is a nonspecific parameter. An elevated RI can differentiate renal artery stenosis from cyclosporine toxicity as a cause of graft failure. This is false. The RI is a nonspecific parameter for renal transplant dysfunction. What ultrasound findings diagnose a urinoma and differentiate it from a lymphocele, seroma, and hematoma? All four of the early ones, the well-defined anechoic fluid collections, these all describe commonly found findings with when you perform an ultrasound. If you were looking for a urinoma, lymphocele, seroma, or hematoma, respectively. The right answer for this question is E, because the ultrasound findings for peritransplant fluid are nonspecific, and a diagnosis of urinoma is only made with percutaneous aspiration and finding that the fluid CR creatinine is greater than the serum creatinine. Question 4. When assessing renal allograft vasculature, which of the following are advantages of magnetic resonance angiography compared with ultrasound or CT? The answer is all of the above. MRI has superior contrast resolution, multiplanar capability, lack of operator dependence, and improved characterization of abnormalities seen on ultrasound or CT. Okay, question 5. I'm sorry about writing such a long question, guys. There's no question on these quizzes that should be this long, really. The correct answer for this one is percutaneous transluminal angioplasty with stent deployment. Basically, I tried to drop every single clue that this patient has a renal artery stenosis, and thrombolytics would be used to treat renal vein thrombosis if surgery wasn't an option. surgical correction wouldn't be indicated in this patient, and graft explantation might be an option later, but we should try to salvage this graft if possible. All right, now here's my references. Thanks for listening to everybody, and I would like to thank Dr. Boehner for allowing me to present in this unconventional way. Sorry I couldn't be there in person. I'm actually on an interview trail right now. So wish everyone good luck, and thanks for listening.